My name is Dr. Edward Ngwenya, and we continue with our podcasts, plastic surgery podcasts, and we are continuing on the skin and soft tissue section, wherein today we'll be discussing a condition that's quite troublesome, to most patients, those that it affects, and that's called hidradenitis suppurativa. Hidradenitis suppurativa will be the discussion topic for today. And again, I repeat, as I do with all the talks and the podcasts that we do, this does not aim to replace your learning, but only to augment your learning. So it assumes that there is some basic concepts that are known, and this is just a high-level, succinct overview to give you a better understanding and a grasp on issues. And it's always imperative that you go back to your books and a few articles and just check. So what is hidradenitis suppurativa? In essence, it's an idiopathic chronic inflammatory condition of what? Of the apocrine gland bearing tissue of the body. So you've got this chronic inflammation that affects apocrine bearing tissue in the skin. And that's important to actually know because it will assist therein in the management. And as I mentioned, certainly in our population group, we see it relatively quite common, especially in view of other comorbid diseases that our patients come with, HIV being one of them, but immunosuppressed patients can have. But I also note that it may happen in patients who are not so immunosuppressed. So it's quite common, generally affecting 8% of the Western population as per literature. But if you look at the demographics, you will find that it's significantly higher in males compared to females. In fact, the ratio it's about 1 to 2.2 to 5 actually times more common in females. Excuse me, I think I said males. In females, more commonly than the males. And there's a reason to this. As you would see already, whenever we speak of demographics, you start to think of the physiology, you start to think of hormones that are at play here. And generally, with that being said, then you would usually see it in a post-pubertal to premenopausal age group. And this varies, the average being around 23 years of age. But it can go anywhere from 12 all the way till 50 years old. The range is quite high. And what we tend to find, specifically in our demographics, is a slight predilection for Africans that seems to come through. Perhaps it's an observation, bias, but nonetheless, that's what we tend to see. And the sites that we commonly see this most predominantly being the axilla, the inguinal region. We also see it in the perineum, perianal region there. Also, basically, in the memory region around the IMF, the buttocks, the pubic region, the chest, the scalp, retroareola. You may even see it on eyelid skin, as one has noted it. But generally, the distribution would be more axilla, inguinal, perineal region, and your pubic area and your memory, inframemory areas. Now, there seems to be as per incidence, a positive family history that can be found in 34% of our patients, but we've not been able to, determine the exact genetic characteristics therein. But we think that there may be a component of an autosomal dominant inheritance therein. Now, what are the etiological factors. What's the etiology? As I've mentioned, we said in our definition, it's an idiopathic chronic inflammatory condition. Therefore, what that already tells you is that etiology is unknown. And the other factors that we then determine or we found out appear to be secondary, and more predisposing, and others more associative, rather than causative factors therein. And what are some of the predisposing factors that we found? Smoking is a big one. Diabetes. So any condition, basically immunosuppressed patients. So diabetes being one. Patients who are RVD reactive. Obesity comes in also as one of the predisposing etiological factors. And perhaps this may reflect a hormonal component, because we see that whenever there's an estrogen-androgen imbalance, or rather when there are increased free estrogen, so these are patients who are on contraceptive, and ovulatory cycles, this would generally increase your chances, or rather predispose one to hidradenitis suppurativa. There are certain chemicals that we've also found to be problematic. Oral lithium. These are patients who've got who've got thyroid problems and who may be on lithium. There are also deodorants that may cause this, and you may find it also in athletes. Because this would generally happen in apocrine regions. So these are patients who've got excessive sweating. As you would find it in the tragenous regions, where this would happen. IMF, inguinal region, axillary being the sites. But it seems to be associated, a strong estrogen immunosuppressive component that then comes in, but also, as I've mentioned, a very strong link that comes in with smoking. And so, what is the pathophysiology? I'm not going to get into the anatomy of the apocrine sweat glands, which are there. But I encourage you all to just go back and revise your anatomy, histology, looking at the skin, and the adnexal structures therein, and where you would find them much greater. But there has been, a couple of theories historically. I remember in my training, certainly, we used to believe, in the occlusion theory, where we believe the occlusion of apocrine sweat glands held, the determining factor, or was the pathophysiological factor therein. And now we seem to understand it further, that actually the problem is with the terminal follicular epithelium within the apocrine gland-bearing skin. And so there seems to be a disorder therein. So succinctly, what happens is, what you get in these terminal follicular epithelium, you get hyperkeratosis that then happens. And this is what will lead to secondary duct obstruction. So now when you've got this duct obstruction, you then have pooling of the apocrine gland contents. And as you know, anything with stagnation, with pooling, it's a good environment that encourages bacterial growth. So bacterial growth will then occur, and mainly these are coagulase negative stuff that would then form them. And so when you have this, call it brewing environment with this bacteria that's brewing in inverted commas, then what you will eventually get is rupture of the follicular epithelium. And when this happens, this now allows the bacteria and the duct contents into the surrounding what? Subdermal tissue. So you having this you have this now happening subdermally, where you've got these bacteria and duct contents in the surrounding subdermal tissue, and this, you can imagine, will now initiate an intense inflammatory response and foreign body reaction that would start to now occur, along with active cellulitis and abscess formation, as you can see the natural history now taking course. And this will lead to destruction of the pilosebaceous unit. And when that happens, eventually it will lead to damage of other adnexal structures within the vicinity. And then what are you going to get? You are now going to get the sinus tracts that start to form. And we think that then happens because these epithelial strands start to be generated. And when you've got an area that's generated from these ruptured follicular epithelium, an area that's epithelialized is no longer closing and forms a fistula, in this case a sinus tract leading downward. And this is the hallmark of established disease, and the other, it's one of the features that our treatment actually then comes in on a more surgical part. And so you can imagine now you've got extensive scarring that now ensues. And then what happens? Everything's got to heal, and it heals by secondary intention. So this is the entire course, the pathophysiology, and thus we are able to actually classify it. Hewley came in and put in the Hewley stages, which are the clinical findings that are dependent on, how the disease has progressed. And so this prognosticates the condition and holds then that value. And the stages follow basically the pathophysiology that we spoke of. So it's divided into 3 stages. There's stage 1, stage 2, and stage 3. Stage 1 is now when we have abscess formation. So it's either single or multiple abscesses that form. However, there is no sequestration or there are no sinus tracts therein. So it's just abscess formation, single or multiple. Stage 2 then is recurrent abscesses, whether single or multiple. And what then do you find specific in this is that now you have these widely separated lesions with cicatrization and sinus tract formation. So that's what differentiates it from stage 1. It's recurrent abscesses, but also you have cicatricial or sinus tracts that then form. And then stage 3 being the worst one, now you've got diffuse disease or near diffuse involvement of multiple interconnected tracts. So now not only do you have these sinuses, but now they are interconnected, and you've got abscess formation in the entire area that is affected. That is stage 3 Herein. And so now, how do we then diagnose this? Whenever we diagnose, remember, we always say on history, you will ask the patient and they will tell you what has happened. Then you examine, and then there are investigations therein. But clearly, this is a clinical diagnosis. And the recent consensus rather suggests that you basically need three key areas that must be included in order to make this diagnosis. Number one are the clinically typical lesions. Two, the characteristic areas. Remember, we said it's apocrine bearing areas. And number three is the recurrence. So, typical lesions, characteristic areas, and the recurrence therein. And what are the typical lesions? We've spoken about, these tender erythematous papules, nodules, abscesses, sinuses, dermal contractures, double-ended comedones, or so-called, they're double-barren patterns. So these are the characteristic, lesions that are there. And what are the characteristics areas or so-called designated sites? We spoke about the axilla, the groin, etc. And so the diagnosis is made when you have active disease with one or more primary lesions at the designated site, plus a history of three or more discharging lumps, and generally it must have happened for a period. So, and that would generally, some books would tell you a designated site since age 10 years. Others would say in active disease, etc., since age 10 years, or all in the absence of a current primary lesion. So the timing thereof, the recurrence is something that's quite important. I'm not going to go into the clinical findings specifically of other areas, but these are some of the things that we have touched on. The histological findings, should you choose to biopsy, they would then come up and also reflect the findings that we spoke about in our physiological natural history. And this is hyperkeratosis of the epithelium. You will have duct obstruction, rupture, intense inflammation, dermal scarring. All those features are those that we'll expect histologically. Now, there's when you look at the British Medical Journal best practice, there are some investigations that have come on as emerging tests, not routinely done specifically, especially in our setting and generally, but these are serum zinc. Perhaps it's something that you need to know about, because if you've got low zinc levels, it can manifest as chronic skin erythema. And this is something that may predispose one to this. So zinc levels and serum interleukin 2 receptors are some of the emerging tests that are come in. And what we found that these levels, the soluble interleukin 2 receptor serum levels, have been found actually to correspond to disease activity. And so you may use this as a biomarker to measure the severity therein in the disease, and also just to assess the efficacy of treatment in the future. But these, as I've mentioned, are not routinely done in our setting. It's a clinical diagnosis. And so once you have it, then we can go into the treatment modalities available. So how do we treat hidradenitis suppurativa? Well, there are general measures, there's topical therapy, there's medical therapy, and then there is surgical therapy, which will include our reconstructive surgeries that we'll do. So what are the general measures that we can implement, and what would you advise the patient? Of course, you would advise that the patient must, have loose clothing, trying to avoid tight jeans, cotton underwears, to wear soft, basically friction-free bras, or rather perhaps even no braziers at all. And so these are now the things that you prefer as opposed to, or as a preference to, tights. And so then there are topical therapies that you may, influence. And remember this, you are guided by the stages they're in. The topical therapies, you would say, look, it's best we use antiseptic soaps and washes. These would include your betadine, your chlorhexidine, berotriclosan, and generally it's just to keep the area clean. And you've got antiperspirant agents that would rather advocate for rather than others, and these generally are products that are in absolute ethanol, such as your 6.25 percent aluminum chloride, hexadrates, and those are some of the things that you may use in assisting you in the management. Topical antibiotic agents, Bactroban, are some that we can then put in. Topical keratolytics, like what's the word? I think it's salicylic acid, your benzyl peroxide. So these are some of the things that can help as keratolytic agents that you may then use topically. But then the what we are then left with are just medical therapies and then surgical therapies. So these would use in combination generally. As per medical therapies, we've got your oral medications, someone coming in, with this active acne problems. And what would we use? We generally use anti-acne antibiotics, and the one that usually comes up as on a chronic phase is doxycycline, and this you'd give it 100 milligrams for 3 to 6 months, or clindamycin 200 milligrams TDS for 3 to 6 months. I've read a couple of other studies. In fact, myself, I've also tried rifampicin, and where I found generally good findings therein. But on an acute phase, what we want to do, simple flucloxacillin, 500 milligrams QID for a week would assist you on an acute phase. And when you see that, fine, we've given this patient for 3 months, it's not really assisting, the disease is the same. By the way, other things you can add are anti-inflammatories, whether your ibuprofen, NSAIDs, steroids, others have given prednisone, Dapsone, even chloroquine has been used on a 150 milligrams daily dose to assist for its anti-inflammatory components, just like Dapsone has an anti-inflammatory component, including, by the way, your doxycycline, which has that when used at a low dose. Other things, I guess maybe this a big one are your isotretinoins, which are actually a treatment mainstay. I use the 60 milligrams daily. Give it to the patient for 6 months. It's a good regime basically to use, and this is a mainstay of our treatment. Your isotretinoins to use. Hormonal therapy, definitely Diane. In fact, 35 in females has shown to actually work quite well in these patients. There's also other agents that are used, but generally you'd find these are Diane, call it products, which include others such as cyprotenerone, acetate, which actually is just Diane, which includes you can add, which includes cyproterone in there. So generally, the regimen that we use would be your doxycycline. Others would use chloroquine, and then Roaccutane is a big one. Roaccutane 60 milligrams daily is the big one that would then help, and oral contraceptives, any of them. But as I've mentioned, remember, N35 has shown to be the best, and it's a must use oral contraceptive because of your isotretinoid. And just have a look, of course. It may work well, especially, you need to put patients on that, females who are, at childbearing age, because of the other effects of, your raw Accutane that are there. So, what are our other treatment modalities that we have? I'm not going to really get into those two biological agents, targeted therapies, infliximabs have been used. We generally don't use them. Radiation, radiotherapy at low grays, 3 to 8 grays as a total dose. There's some reports, laser, photodynamic therapy, but generally, we mix our general measures, and in these cases, not so effective for 3 months. Others would say 6 months to the year. Now we must offer surgical modalities and therapies for these. And what are some of the surgical modalities that are there? And the basic simple one, it's resection. Radical surgical excision of that entire affected area. And this will include all macroscopically affected tissues. Some would say you take even a 2 centimeter border around this. And what I like to use, as recommended, are starch tests. What you do, you use starch. There's a minus test that you use, and it's starch with iodine, and then basically it turns black, and you remove that entire region that is black. Of course, you've got to, in patients who are not sweating, just ensures that you may put your air conditioner heater on and make the room hot, and so you would physically actually see it turning black in front of you, and then you would then go in and then excise radically. Others have used carbon dioxide lasers as ablative in excising this tissue. And now you've excised, what are you going to do? You've got this now tissue that's excised. What do you then do? Others would say, look, put in a skin graft. But we know it's the axilla, it's going to contract, might be a problem. Others say, no, leave it. Don't do anything, just leave it as is. Don't put a skin graft, leave it raw, and just do dressings. Of course, it's going to take a while, but it does contract. And I've seen some that have actually healed fairly well. But what generally most of us plastic surgeons would then do would rather, put in a flap in that area, and you've got options, in that area. Generally, you are unable to primarily close this, so a flap cover generally is the best option. And we've got your TDAPs that we can use, thoracodorsal, tap flaps for the axilla, periscapula is also right there, but some people may choose to raise a free flap, an ALT, anterior lateral thigh flap, or tensor fascia lata for the groin, and you just pedicled and you put it in that area. So axilla generally, you may even be able to raise V and Y flaps, which I've used quite a lot. You just put a VY advancement flap, taking advantage of your thoracodorsal artery perforators therein, and just advance it there on that side, or you may just rotate some areas therein. Sometimes the arm also may offer you some, laxity to be able to advance the inner arm therein, but that would generally leave a scar on the arm of the patient. But parascapular flaps, thoracodorsal flaps, good options for the axilla, and for the groin, your ALT, your tensor fascia lata, good options. I like even the tensor fascia lata, quite easy. You raise it, can cover quite a good area there. But your ALT is got, you can have a large size and with minimal donor site morbidity therein. Tissue expanders have been mentioned. They can be used, and then you advance just the local tissue, but generally not done in the acute phase, but maybe for secondary stages. After skin graft closure, you may then use it. You've closed with the skin graft, you put in an expander, and then you remove the skin graft and advance the skin therein. What are some of the complications that we may have? Well, of course, infection, both local and systemic. There may be septicemia, contractures very big. You will get fibrosis, scarring that may lead to contractures, and it limits the range of movement therein. Lymphatic destruction with lymphedema. Some may even have, elephantiasis that then follows. And then, of course, other systemic measures secondary to chronic inflammation, such as proteinuria, hypoproteinemia, amyloidosis, anemia, renal disease, rare, but you may have those systemic manifestation. There's a component which I've read about, but just on just one or two, which is a Marjolines ulcer that may form. Generally, it's from burns, but I've seen something that's been described, from long-standing fistulas that may be complicated by the development of a squamous cell carcinoma. But it's generally something quite rare, and it must be there for quite a long time. But just keep that. Recurrence is a big thing. As after surgical excision, the value that's quoted is 2.5%. Generally not in the IMF. What do you call this? Generally less in the other areas, axilla, but the IMF has been one that's actually come with a higher recurrence rate, up to 50%. And of course, perhaps because you still have the breast mounting that intertriginous region that's there, or perhaps even the resection. Others may be conservative in trying not to violate the IMF and maintain that. E1 wonders, but there are many other postulations that are there. There are other disease associated, with long-standing disease, seronegative arthritis, pyoderma, gangrenosum, but these, just things that you'd keep way at the bottom of your list of complications. I think with this, we've covered hidradenitis suppurativa, and with this information, you should be able to manage any patient that comes with hidradenitis suppurativa. I thank you for your attention. Until our next talk. Ciao.